Thanks, Paula. So the National Safer Supply Community of Practice, just a quick introduction to who we are for those of you who do not know us. We are funded by Health Canada's Substance Use and Addictions Program. Our mandate is to support the scale of safer supply programs through capacity building and knowledge exchange. The focus of our work is a medicalized model of safer supply, although we also engage in a lot of discussion and advocacy for non-medicalized models as well. We are a collaboration that exists between London Intercommunity Health Centre, the Canadian Association of People Who Use Drugs, and the Alliance for Healthier Communities. And we do a lot of knowledge exchange events and activities, workshops, webinars, conferences. We have working groups addressing different aspects of safer supply. We have a safer supply prescriber consultation line and engage in a lot of networking and community building. We also have an amazing website that I encourage you all to visit, which has an incredible research library and also houses archives of past webinars that we've held. We will be offering a certificate of attendance for today's event. We'll stick the link in the chat, and you'll be able to just like go to the link and put your name in, and you'll get a certificate sent to you. And then just a quick plug for our August Hot Topic event. We have organized a panel discussion on harm reduction, safe supply, and experiences of pre and perinatal care. So hope to see you there at that event. It's also a Zoom webinar, and that's August 25th. From 12 to 1:30 p.m. Eastern Time. And yes, check out our website for our resources and registration for events, and to join our community of practice. We're now over 900 members, interdisciplinary community, and we'd love to have you join us. All right, enough from me. Let me pass it over to you, Chris, and thank you all very much for joining us.
Great, thank you, Rebecca. So hi, everyone. So my name is Chris Hoy. I'm the manager of Hepatitis C Knowledge Exchange and Community Program at CATIE, and I'll be moderating the discussion today. So for those who are not familiar, CATIE is Canada's source for hepatitis C and HIV information. We're the national knowledge exchange and do national knowledge exchange work and capacity building work around hepatitis C, HIV, and harm reduction. So thank you to the National Safer Supply Community of Practice for hosting us and having us on this session today. So before we begin, we'd like to acknowledge that the audience and presenters in today's webinar are based across the country on traditional lands and territories. So we'd like to acknowledge those lands and the original people who lived on them. CATIE, as well as myself, are based in Toronto, which is the traditional territories of the Wendat, Anishinaabe, Haudenosaunee, and the Mississaugas of the Credit. And when we're thinking about harm reduction, hepatitis C practice, as well as the overdose crisis, and drug poisoning crisis, Indigenous peoples are at the front and center of this. So recognizing that both our own practice and harm reduction practice also needs to be reconciliatory practice. And we strive to confront and challenge colonial structures and colonial mindsets that are in place. So thanks for joining us today. So I just want to share first off, so if we can go to the next slide, that today is, as Rebecca mentioned, World Hepatitis Day. So World Hepatitis Day is an international occasion to raise awareness around viral hepatitis, as well as the global efforts that are underway to reach the elimination of hepatitis, including hepatitis C, which is what we'll be focusing on today. So on the next slide, I just wanted to start off by setting the stage for hepatitis C and why it matters for safer supply providers. Sorry, it says prescribers there, but I meant providers. So first off, people who use drugs are disproportionately affected by hepatitis C. We'll get to some of the specific stats later, but we know most new cases of hepatitis C occur among people who use drugs. And because of this, hepatitis C is part of an overall holistic approach for the health of people who use drugs. But hepatitis C is curable, and treatment that is available today is highly effective, including for people who use drugs, as well as for people who are currently using as well. So hepatitis C treatment is simpler than ever for people to complete, but it's also simpler than ever for providers to provide treatment as well. As a country, Canada is striving to reach hepatitis C elimination, which is possible because we have this highly effective cure. And so as we ramp up testing and treatment, safer supply providers are ideally placed to support people who use drugs through testing and treatment due to these existing trusting relationships and the low barrier nature of safer supply programs. So these are some of the key messages that I want folks to keep in mind today, and we'll definitely revisit these themes throughout today's presentations. So we'll take a quick look at today's agenda and panelists. So first off, we're going to do an overview of hepatitis C testing, treatment, and prevention to give you the basics of what you need to know from CATIE's resident hepatitis C expert, Rivka Kushner. So next after that, we'll hear from three panelists who are actually members of the Safer Supply Community Practice, who are going to share their program examples of how they're already integrating hepatitis C and safer supply practice together. So we'll have Dr. Tim O'Shea, who's based in Hamilton, Patty Wilson, based in Calgary, and Angie Austin and Jessica Nanny based in Toronto. So we'll have time at the end to answer any audience questions as well as have a discussion with our panelists. So if you have any questions, comments, or want to share some of your own insights, feel free to leave those in the chat box, and we'll definitely keep an eye on that. So with that, I'll pass it over to my colleague Rivka for her presentation.
Great. Thank you so much, Chris. I'm really grateful to be here today, joining as an uninvited settler on the unceded, ancestral, and stolen lands of the Musqueam, Squamish, and Tsleil-Waututh nations in what is colonially known as Vancouver. So as Chris stated, people who use drugs are disproportionately affected by hepatitis C. Here is a screenshot of a recent infographic developed by the Public Health Agency of Canada on people living with hepatitis C in Canada in 2019. And I just want to highlight some of the information here. So in 2019, about 1% of the population in Canada had ever had hepatitis C. However, alarmingly, 45% of people who inject drugs had ever had hepatitis C. And this represented 175,000 people who inject drugs in Canada in 2019. As well, 1 in 4 people were not aware of their current or past hepatitis C infection, and therefore they could benefit from getting tested. Now, focusing on people with a current chronic hepatitis C infection, so that's a hepatitis C infection for longer than 6 months, which will need treatment in order to be cured, we see here that 1 in 4 people who inject drugs had a chronic hepatitis C infection in 2019, and therefore could benefit from treatment to be cured of hepatitis C. And you can also see here that there's other populations who are disproportionately affected by hepatitis C, such as people who are incarcerated, Indigenous peoples, and gay and bisexual men and other men who have sex with men. And of course, people who use drugs can also be part of these other communities as well, and multiple of these communities. So the Public Health Agency of Canada data focused on hepatitis C infections among people who inject drugs. And while sharing and reusing equipment used for injecting drugs is the most common way people get new hepatitis C infections in Canada today, I want to highlight that hepatitis C can also be passed through sharing pipes and mouthpieces used for smoking drugs, and straws or rolled paper used for snorting drugs. So as safer supply providers and people supporting safer supply prescribing and people who use drugs, you're already participating in supporting hepatitis C prevention through your work in harm reduction. So you don't need me to tell you how to go about preventing hepatitis C. And so for the rest of the presentation, I'll focus on sharing additional information about hepatitis C with some basics, and then moving on to testing and treatment and how that can relate to your work. So starting with a few basics, hepatitis C is a virus that injures the liver. And over time, if the virus is left untreated, more and more of the liver becomes injured. And people with advanced liver injury called cirrhosis have an increased risk of liver cancer, which is called hepatocellular carcinoma, as well as liver failure. Hepatitis C doesn't just affect the liver, though. It is a systemic infection. So hepatitis C is associated with diseases that affect many different systems and organs in the body, including the immune system, renal, endocrine, cardiovascular, and circulatory, the nervous system. Psychiatric hepatitis C is associated with depression, lungs, skin, metabolic disease, and thyroid. There are two phases of a hepatitis C infection. The acute phase refers to the first phase of the disease. So that's when a person is newly infected. And at this stage, about 1 in 4 people will clear the virus from their body within the first 6 months. However, the remaining 3 in 4 people will go on to have what we call a chronic hepatitis C infection. So that's a hepatitis C infection for more than 6 months. And those people will need treatment in order to be cured of their infection. As well, another key feature of hepatitis C is that there is no immunity to hepatitis C. So a person can be reinfected with hepatitis C if they are exposed to the virus again. And that includes both people who cleared their infection within the first 6 months within that acute phase, and also people who were cured through treatment. Very few people show symptoms early on in a hepatitis C infection, and many people have hepatitis C for years, often decades, before any symptoms develop. Hepatitis C is often called a silent disease because most people won't have any symptoms until they have very advanced liver injury. And so that really emphasizes the importance of routine testing. And of course, early diagnosis is beneficial because over time, that untreated chronic hepatitis C infection can lead to the severe liver injury that we just talked about, liver cancer, liver failure, and affect other systems in the body as well. So as Chris said, though, there is really good news, which is that there has been a treatment revolution in hepatitis C. And in recent years, hepatitis C became the first curable chronic viral infection. And these treatments now are safe, highly effective. They're called direct-acting antivirals, and they cure hepatitis C in about 8 or 12 weeks. So hepatitis C does have long-term health impacts, but being cured has both short and long-term health benefits. A recent research study out of British Columbia found that being treated and cured of hepatitis C was associated with a dramatic reduction in deaths from all causes. We can see here that being cured will prevent future liver injury caused by hepatitis C, liver failure, and lowers the chances of developing liver cancer. Being cured also reduces the risk of those non-liver related diseases associated with the hepatitis C virus, such as diabetes, kidney disease, stroke, heart disease, and more. People who are cured of hepatitis C will often talk about an improved quality of life, for example, more energy and less body pain. And the liver is a resilient organ, and so liver health can also improve over time after being cured. And what I've just stated are all individual benefits to being cured of hepatitis C, and I really want to emphasize those and focus on those. But it is also, I think, relevant to mention that there are the broader community benefits, public health benefits that we call treatment as prevention. So the fewer people who have hepatitis C, there is less overall risk of onward transmission. Experts in Canada have put together hepatitis C treatment guidelines in 2018. And these treatment guidelines really clearly state that treatment is recommended for all, that Canadian hepatitis C treatment guidelines recommend that all people with chronic hepatitis C be considered for treatment. And treatment is highly effective at curing hepatitis C among people who are currently using drugs. However, as you well know, people who use drugs experience significant stigma and discrimination and often have inequitable access to healthcare. And so these factors are significant barriers to accessing hepatitis C treatment. And as such, people who use drugs are traditionally an underserved population when it comes to hepatitis C treatment. So hepatitis C treatment can still be a point of contention for some healthcare providers to provide treatment for people who use drugs. And so CATIE developed a statement on hepatitis C treatment efficacy among people who use drugs to help distill some of these misconceptions related to hepatitis C treatment, summarize the available evidence, and ultimately develop a tool to support access to treatment among people who use drugs. And I'll refer to this a few times in the presentation. So who can do testing and who can offer treatment? With recent advances in hepatitis C treatment, there's been a large shift in how hepatitis C treatment is offered. And as people who support or prescribe safer supply, we think that you're in a really strong position to integrate hepatitis C testing and treatment into the holistic care offered to people who use drugs in your care. So hepatitis C testing and treatment have come a long way with a bit of additional training or mentorship. Non-specialist providers such as family physicians and often nurse practitioners can prescribe hepatitis C treatment. In many community hepatitis C programs, nurses oversee a lot of the testing and the treatment alongside that partner prescribing physician. As well, we want to emphasize that non-clinical providers play a key role in hepatitis C prevention and education, and also to support people as they are completing treatment. In some regions, non-clinical providers also perform hepatitis C testing, particularly with point of care testing or dried blood spot testing, and I'll talk about that in a few slides. And then finally, Canada is a really big country with variations between provinces, territories, and regions. So we just encourage you to confirm with your local health authority or professional association about what is possible where you are. So in Canada, hepatitis C testing is recommended for all people at ongoing risk of hepatitis C, and that includes people who use drugs. And it's recommended that people at ongoing risk of hepatitis C infection are tested every 6 to 12 months. There are typically two tests required to diagnose a hepatitis C infection. The first test is a screening test, and this checks whether a person has ever been exposed to the hepatitis C virus. So this is looking for antibodies to the hepatitis C virus. And then the second test is a confirmatory test, and this checks if a person currently has a hepatitis C infection. And this is typically an RNA test in Canada. And all hepatitis C tests in Canada require a blood sample. So diving into that screening test that looks for those hepatitis C antibodies. A positive result to this test means that a person has been exposed to the hepatitis C virus. However, the antibody test alone does not indicate whether a person has that current chronic hepatitis C infection. If the screening test is positive, then the person will need to go on to have that confirmatory test, which checks for the presence of the hepatitis C virus. And a positive result of this confirmatory test means that a person has a current hepatitis C infection. And I'll just note that if that first test, the screening test, is positive, but then this confirmatory test result is negative, it means that a person no longer has hepatitis C. So that could be the result of the person spontaneously clearing hepatitis C in the first 6 months of their infection, or because they've had treatment that cured their hepatitis C infection. So a note that sometimes these tests are done in 2 steps. And so though that would mean having to provide 2 blood samples at 2 different times. So if the screening test is positive, a person would have to return to provide a blood sample for the confirmatory test. However, in some regions, these tests are done in 1 step, which we call reflex testing, where a person only needs to provide a blood sample at 1 point in time. And then if that screening test is positive for hepatitis C antibodies, the same blood sample is going to be used to test for the presence of the hepatitis C virus. But again, I emphasize that you want to check what is available for you in your region when it comes to ordering hepatitis C tests. So hepatitis C reinfection is possible. And so for somebody who might be at risk of reinfection and you're wanting to check that, only the second test, that confirmatory test, should be offered for testing reinfection. And that's because hepatitis C antibodies remain present for the rest of a person's life. And so we know that their antibody test is positive. So just that confirmatory test to check for the presence of the hepatitis C virus would be used. There are a few different types of tests available in Canada for hepatitis C, but I really want to emphasize that by far, most people will go through this standard blood draw process where you'd have venipuncture to have a blood sample taken and then delivered to a central lab to analyze the test. Dried blood spot testing is when a blood sample is collected from a finger prick, dried on a paper card, and sent to a laboratory for analysis. And dry blood spot testing collects multiple spots of blood on one card. Therefore, it can be used for both the screening and the confirmatory test. And another benefit of dry blood spot testing is that it can help to reach people in rural and remote communities. However, very few laboratories in Canada are currently able to process dry blood spot testing cards. Then the third type of test available to some degree in Canada is a point of care test. And it's this point of care test specifically that's on the screen. So a point of care test is analyzed at the site where the sample is collected, so at the point of care, as opposed to being sent to the lab for analysis. And in Canada, we have one point of care test approved for use. It is the OraQuick Rapid Hepatitis C Rapid Antibody Test pictured here. So that is the antibody test, the screening test, and it detects results in about 20 minutes. I do want to mention, though, that point of care testing for hepatitis C is not publicly funded in Canada. And so these tests are only available in some locations, typically through private funding or through research centers. So moving on to hepatitis C treatment, a person in your care has that positive confirmatory test. You know that they have a current chronic hepatitis C infection. So what is next? I just want to start by really emphasizing how far hepatitis C treatment has come. And, you know, we haven't had interferon treatment for many years in Canada. That's that old type of treatment. But sometimes people are still thinking about interferon treatment when they're having conversations about hepatitis C treatment. And so I wanted to just highlight the differences in case that's part of the conversations you have. So interferon treatment was taken through injections, had a really long list of side effects that were quite debilitating. It was taken for 6 to 12 months, and the cure rate was about 50%. However, the current treatments that we have now, called direct-acting antivirals, these are the only treatments available in Canada. They are taken as pills orally. There's a relatively short list of side effects that are fairly mild. I'll go into them in a few slides. Treatment is typically taken for 8 or 12 weeks, and people have a 95% chance of being cured with one round of treatment. So highly effective and a total game changer when it comes to hepatitis C treatment. Looking at that CATIE statement briefly, I just wanted to highlight and emphasize a few of the key messages that are right on that first page of the CATIE statement. So one, hepatitis C treatment is highly effective at curing hepatitis C for all people, including people currently using drugs, including people on opioid agonist treatment. And people who use drugs should be offered hepatitis C treatment regardless of whether they plan to continue, reduce, or stop their use of substances. We want to really normalize hepatitis C reinfections. They can happen, and treatment for reinfection is the same as if a person is receiving treatment for the first time. And so people who use drugs should have access to treatment for hepatitis C reinfection. As well, hepatitis C treatment should be offered to people who use drugs in conjunction with other services that support overall health, such as harm reduction services, such as safer supply, which is why we really wanted to have this conversation with everybody here today. And that linkage to harm reduction and prevention services will also reduce the likelihood of a hepatitis C reinfection. And then hepatitis C treatment can be a positive and stabilizing factor in a person's life, especially when it's combined with that additional care and support that addresses underlying health and social issues and is really in alignment with a person's goals. And so again, safer supply services are a really great place to integrate hepatitis C treatment because of the services that you're already providing to support holistic health for people who use drugs. So a quick look at the nuts and bolts of hepatitis C treatment. Here's a table that has common hepatitis C treatments available in Canada for adults. But really these days, people are offered one of two treatments. The first is called Epclusa, and it is a treatment that is highly effective for all genotypes, all types of hepatitis C. It's taken as one pill once a day for 12 weeks. And then the other option is also effective for all genotypes of the hepatitis C virus. It's called Mavorite, and it's taken as 3 pills once a day, typically for 8 weeks. but Mavorit should be taken with food, but any type of food. And integrating hepatitis C treatment for people who are already receiving a regular dispensing of medications such as safer supply can be a fairly streamlined way to integrate hepatitis C treatment by just adding on those treatment pills with that regular dispensing. So I'd mentioned side effects briefly before. They're generally mild and usually stop or decrease a few weeks after starting treatment. The most common ones are nausea, extreme tiredness, headache, and diarrhea. There are a few considerations for choosing between typically those two treatments that I mentioned earlier. It can include the amount of liver injury that a person has, a review of drug-drug interactions, and then often it's really about patient preference for those 3 pills once a day for 8 weeks taken with food, or 1 pill once a day for 12 weeks. If a person is really keen to have hepatitis C treatment, there's typically one big reason to consider delaying treatment, and that would be if a person is pregnant or trying to get pregnant. When it comes to treatment coverage across Canada, usually a person does not need to pay out of pocket for hepatitis C treatment. So most people are covered through public health insurance plans. Some people are covered through private health insurance plans, such as through work. And the drug companies who manufacture hepatitis C treatments have support programs that can be really helpful because they can support with paperwork, for example, for Trillium in Ontario to get access to public health insurance. And they can also cover any deductibles that a person is charged through that public or private health insurance. So when we come to cure for hepatitis C, cure is often called a sustained virological response. And it is when a person has an undetectable hepatitis C viral load 12 weeks after the end of treatment. So that means that there is no more hepatitis C virus in the person's body and they are cured. And I just wanted to highlight, and I think the panel later will also potentially reflect on this, which is that we often hear that hepatitis C treatment as being able to offer a cure for a chronic viral infection can be a really rewarding and satisfying experience to be part of, because it's not often in medicine that something has such a high cure rate and is relatively simple to go through. So after treatment and cure, if a person does not have advanced liver injury, there is no follow-up required related to their chronic hepatitis C infection. However, for people who may continue to be exposed to hepatitis C, they are at ongoing risk of a reinfection. And so they're offering ongoing resources and support related to harm reduction to prevent a hepatitis C infection would be really key. And then offering testing to assess for reinfection every 6 to 12 months. So treatment for hepatitis C reinfection, we really want to normalize reinfection. It can happen, and people who use drugs should have access to treatment for reinfection. Those treatment protocols are the same whether a person is receiving treatment for the first time for their first hepatitis C infection or for a reinfection. And sometimes reinfection is cited as a concern among healthcare providers as a reason why they might be reluctant to offer treatment to people who use drugs. However, we really want to emphasize that there are those significant individual health benefits of being cured of hepatitis C. It would be important to emphasize harm reduction and linkage to resources and education to try to prevent future reinfections. But then there's also that community benefit, that greater public health benefit of preventing onward transmission. So treatment is highly effective at curing people who use drugs with hepatitis C. And we've said this a few times, but I just want to really drive home that there is a strong body of evidence that demonstrates how effective it is, including for people who are currently using drugs, people on opioid agonist treatment, and we'd expect the same for people who are taking safer supply. Sometimes we also get questions about adherence to hepatitis C treatment. So a concern that maybe somebody who's using drugs wouldn't be adherent, wouldn't be taking their pills every day. But the evidence suggests that there's no significant difference in treatment adherence among people who use drugs and people who don't use drugs. And as well, there's also a body of evidence that looks at how forgiving hepatitis C treatment is. It is really highly effective. And so research on adherence among people who use drugs among who are not perfectly adherent to hepatitis C. So in the research, that's defined as taking less than 90% of the treatment pills, shows that treatment is still really effective and cure rates are not significantly different. So finally, just to close again with a look at these 4 key messages from the CATIE statement on hepatitis C treatment efficacy among people who use drugs. Treatment is highly effective at curing hepatitis C for all people, including people who use drugs. Hepatitis C reinfections are going to happen. They should be normalized, and people should have access to treatment for reinfection without stigma. And then hepatitis C treatment should be offered to people who use drugs with that wraparound services that support overall health and well-being, such as safer supply programs. And then just really emphasizing that treatment cures a chronic viral hepatitis C infection. And so it can be a really positive factor in a person's life, especially when combined with those other care and supports. All right, so I will pass it over to Chris now.
Great, thank you, Rivka, for that presentation. So I know for everyone that was likely felt like maybe a whirlwind of information, but we're hoping that it gave you the foundation of information that you'll need for the rest of this session, but also to begin thinking about what hepatitis C care could look like as part of your practice. So if you need a recap, we can definitely share these slides and they'll be posted to the Community of Practice website, as well as the recordings, so you could rewatch this presentation as needed. And if you need as well, all this information that Rivka presented is also available on our website, which is at catie.ca. So I just also want to quickly highlight some key messages from today to hopefully convince you that hepatitis C practice is something that could be part of your safer supply program. So, Rivka had already mentioned all of these, but just to highlight a few things. So again, treatment is highly effective and safe for people who use drugs. There's a ton of research to show that with the right supports in place, people who use drugs, including people who are actively using, can be highly successful in reaching hepatitis C cure. Curing hepatitis C can halt and even potentially help reverse liver injury, has global improvements in quality of life, including emotional and mental well-being, as well as immediate benefits in preventing future transmission. And for the audience today, like safer supply programs are routine, trusted clinical touch points, and often the only ones for many people who use drugs. So this makes you the perfect provider to deliver and oversee hepatitis C care. As we know, many folks often face stigma, discrimination, and more from the mainstream health system. And also for you as a provider, hepatitis C testing and treatment has never been easier. With some supports, you can definitely get started, and it also fits within a holistic healthcare approach for people who use drugs. And so we'll go to the next slide. And so hopefully at this point, you're on board and you're convinced you want to get ready to become involved with hepatitis C. So what comes next? So as a follow-up today, CATIE is also planning a couple additional trainings that we're providing specifically for the National Safer Supply Community of Practice. Both of these trainings are free to attend. So the first is a training for clinical staff who are thinking of starting to prescribe and lead hepatitis C treatment. So this training is being delivered by 2 organizations called ASHM and INSU that are international organizations focused on education around health and hepatitis for people who use drugs. This course is a combination of some self-directed online learning, as well as a live interactive online workshop that's going to be on September 15th. So this course is also accredited, and I believe CME credits should be available for all regions in Canada. So the second one is being led by CATIE, and this one is intended for non-clinical staff or staff who are not going to be doing the clinical aspects of hepatitis C care, but are going to be primarily supporting clients through education, prevention, and adherence support during treatment as well. So this is also a two-part training with first is a self-paced but facilitated online course, culminating in also a live interactive online workshop, which will be in October. And for this one, a certificate of completion can be provided. So we'll share the registration details for these shortly through email through the Safer Supply Community of Practice, as well as on the Google discussion group. And if you can't make these workshops, we'd encourage you to search out what's available in your region as well. We know many provinces and territories have other hepatitis C training opportunities available. So for example, I know in a few provinces, they hold the ECHO programs, which are hub and spoke clinical support programs for providers as well. And I won't go through them now just for the sake of time, but CATIE also has a few other resources which may be helpful in your hepatitis C practice. We have some online learning that you can take self-paced, free client resources that can be mailed to you that you can use with your clients. And then also a directory of other hepatitis C, HIV, sexual health and harm reduction services in Canada. So in the case that you decide you're not ready to provide these services yet, you can find someone in your community who is. Okay, so with that, we're now ready to hear from our panelists who will share a bit about their hepatitis C programs. So first up, I'll ask Dr. Timo Shea to join us on camera. Oh, there he is. Okay, so yeah, I'll pass it over to you shortly. But just a reminder, we'll have some time at the end for discussion and questions. So please feel free to leave them in the chat box or the Q&A box. So Tim, over to you.
Thanks very much, Chris, and thanks everybody for giving me the opportunity to talk briefly today. I'm joining you from Hamilton, Ontario, which is the traditional lands of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. So I've been asked to talk a little bit about my practice as it relates to safe supply and Hep C treatments. And I will make my remarks fairly brief because I think it's really actually quite simple. And I could probably just summarize it in 30 seconds and then move on, but I'll talk a little bit longer than that. The sort of napping summary, I think, is that, and the lesson that I've learned by prescribing Hep C treatment along with safe supply is that when as healthcare providers, we listen to our patients and hear about what their priorities are and then address those priorities, the benefits in terms of our ability to intervene in other areas of their health becomes so much greater. So just in terms of background, I'm an infectious disease specialist and have gone through different paradigms of Hep C treatment, including the era of interferon and moving into the newer era when we have much more effective treatments. And initially I was mostly hospital-based and then have moved more into community-based practice. And I have been in discussions or have seen patients who have come to hospital-based settings or to other more clinical-based settings who have hepatitis C infection or HIV infection, which is the other area that I practice in primarily. And I've been part of discussions where either clinicians will say, we shouldn't be offering treatment because there's no way somebody's going to be able to adhere to it. We hear that quite a lot. Or if treatment is started and then not completed, well, obviously this person doesn't care about their health very much. What can we do? We can't really do much about that at all. And I think that type of an attitude is extremely common in the healthcare system broadly. And it really just is so obviously wrong. I don't know why it's not challenged more. And so really for me, I came to safe supply through HIV treatment mostly, and my patients were struggling with being able to adhere to treatment, being able to really prioritize that aspect of their health when so much of their time, energy, et cetera, was being spent on surviving in a extremely unsafe world, dealing with the toxic drug supply, dealing with overdose risk, dealing with criminalization, homelessness and poverty, and all the other things that go along with the policies we put around drug use. And so it really wasn't much of a surprise that, taking a pill every single day became less of a priority when all those other things were filling up people's minds and time. And so certainly by listening to my patients and talking to them about what it was that was getting in the way of them being able to engage in that treatment, as well as by talking to some of the pioneers in safer supply prescribing locally in Ontario, I started to co-prescribe safe supply with HIV treatments. And again, it shouldn't be a surprise really, but I'm not sure why it took me so long to realize this. Again, if I'm dealing with the priorities and the issues that my patients are identifying as the most important, it became very simple and easy to do it to also treat HIV infection. And then that moved into Hep C treatment. So I now practice out of a clinic called the Support and Safer Supply Clinic in Hamilton. We have recently been funded through Health Canada through the SUAP program. And so I've been able to expand our program. And I think the key points for me, which I'll just highlight in terms of the lessons that I've learned in terms of being effective in treating Hep C along with providing safer supply. I think our clinic is very lucky to be located in a setting that's not extremely clinical. We chose to partner with a local organization, the Hamilton AIDS Network, where the community was comfortable going already. It was one of the main areas in the city where people were sourcing harm reduction supplies. It's an organization that has put time and effort into building links to the community, making people feel welcome, which is obviously very different than the experience that many of my patients have had in more traditional healthcare settings. And we also partnered with Keeping Six, which is an organization of people who use drugs and those that love and support them. Keeping Six runs a drop-in on the Tuesday afternoons when I run my clinic at the AIDS Network, which again just makes it more of a community feel, makes it feel less clinical and more welcoming. And so it's a place where people were comfortable being, which helped break down some of the barriers and reluctance to engage in healthcare. Secondly, we have been able in the past to offer on-site testing, which has been extremely helpful, initially through the kindness of a local RN who volunteered her time coming to the clinic and drew blood for us. And now with our funding, being able to hire an RN to do that work, that's been a huge help in terms of getting the testing done, being able to draw the blood right on site while people are there. The other piece I think that's been beneficial to us is that we do have integration with other healthcare organizations in the city. And so the 3 physicians that are prescribing now at our program all work in the inpatient addictions program in Hamilton as well. And so we have good links to the hospital system. Again, unfortunately, many of the harms that my patients were experiencing before are still there. And so oftentimes they do end up in hospital. That allows us to make sure their treatment continues when they're in hospital. There's no interruptions. And things move smoothly in that setting. What else was I going to say? The other piece I think that was helpful for me, like I said, I'm trained as an infectious diseases specialist, but I'm not in any way a subspecialist in hepatitis C care. And so for me, having a link to some of our local experts who are very available and willing to offer quick answers to questions if I do have them about more complicated cases has been very helpful. I think in the initial presentation, when it was mentioned that really this is fairly straightforward and simple, really now the treatment is pretty easy to do. And with a little bit of mentorship and training, most people can do it. I think that's entirely true, but it is helpful to know where those resources are so that if you do have questions, you've got somebody to coach you through it. And then obviously your experience and your knowledge will grow as you're able to do that. I think I'm going to stop there so that I can give time to the other panelists to speak as well. And then I'd be happy to answer questions at the end. Thank you very much.
Great, thank you for that. I think particularly your point around integration of services being a key part of your program, I think is certainly a theme that will come up again today. And I think, as we think about how we can expand hepatitis C programs, I think that key of integrating into places that are already trusted providers is a very important element of that. Okay, so next I'll invite Patty. Patty's a nurse practitioner based in Calgary to share a bit about her practice. So Patty, over to you.
Yeah, thanks for that, Chris. Hi, my name's Patty Wilson. I'm calling in today from the Traditional Territories of the People of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising of Siksika, Piikani, Kainai, the Tsuut'ina, the Stoney Dakota First Nations, including the Chiniki, Bearspaw, Wesley First Nations. This is also home to Métis Nation of Alberta Region 3. I did actually prepare some slides, so I'm going to share my screen now. Okay. And folks can see that okay? Yeah, okay, perfect. All right. So I actually work in an outreach setting. So it's myself and an RN, and we actually go to a harm reduction building where folks live. It's an apartment complex, and there's about 20 to 25 folks that live in these buildings. Let's see here. So the way it's sort of structured and the sort of the staffing of what that looks like is that I'm able to provide about 4 hours a week per building, and similarly, and then we have an infectious disease specialist who we can consult as we need. As I said, there's about 20 to 25 clients. These buildings are staffed 24/7 by caseworkers, about 2 to 3 caseworkers in the building. And so what happened is that with these buildings, our role, the RN and myself, we are providing primary care to the buildings. And that's sort of the structure that we started with. And already in place when the RN and myself started up, there was already a managed alcohol program that was in place, and we are providing primary care to these folks. And then what we started to do is we started to scaffold in hepatitis C treatment to that. And this was all sort of pre-COVID and BCCSU risk mitigation guidance document. And it was a very much, harm reduction focus. So there were, harm reduction supplies, and the way the program works is that medications are delivered by a pharmacy every week in blister packs, and the caseworkers, they dispense the medications daily. So it's, we're very fortunate in that case that it's a really, it's a building that is already it's already very supportive for folks. It has a very supportive, and so in all of the senses, it's supportive in terms of the philosophy of the building. It's supportive in terms of the staffing, and it's also supportive, from a medical perspective, in that the medication is delivered. And we also have the staffing hours there, which is really, really lovely. The other thing that, COVID, no one would ever say that we wanted this to happen. It was a horrible thing. That being said, when COVID did happen, the sort of requirement before, the structure we had before COVID for folks who wanted to start hepatitis C treatment is before we required folks to get fiber scans, which is like an imaging of the liver. And so they obviously had to go outside the building to get that done. Once that happened, once COVID, became our new reality, we realized we still wanted folks to engage in treatment and start hepatitis C, and folks also wanted to do that. And it just became, one extra barrier that just wasn't happening. And so we started to look at, is this possible for us just not to do this and just to go based off of blood work and do calculations based on their blood work? And so we actually dropped, and also the rest of Alberta dropped the requirement for fiber scans to get done. And so that became even less of a barrier. So we were actually able to bring all of hepatitis C assessment and starting medication into the building exclusively, because we're able to do blood draws in the building, which is really excellent. And then BCCSU released their risk mitigation guidance document in March of 2020. So we were able to start that up in the building as well. So we can do pretty much everything in building for these folks, which is really quite lovely. And then also still maintaining that managed alcohol program as well. Okay. And so just to take you through like what a client pathway looks like for someone who is, let's say, moving into these buildings for the first time. So first we get them started and get them connected to medication coverage. And then usually with clients, myself or the RN would meet with them, and we create what we call like sort of a wish list with the client. We meet with them, we say, these are sort of a list of all the possible services we can offer them. We can get you connected to Hep C treatment, we can get you connected to Safe Supply or OAT, or get you started on PrEP if that's something that you would like, get you started on gender affirming care, testosterone replacement for hypogonadism, get you started on like blood pressure medication, whatever that may be. We sort of create like a big wish list, and then we prioritize what they would like to get started. And top of that list, 9 times out of 10 is going to be Hep C treatment, and it's going to be Safe Supply. Maybe even higher than 9 times out of 10, honestly. So which is really nice, because in that moment we try to chat about what do they know about Hep C treatment, and what does that look like, and what is required with that. And honestly, most of the time, their knowledge, folks' knowledge of DAA treatment is pretty low. They're still thinking of interferon days most of the time. And so being able to discuss cure rates and low side effects is really rewarding and really exciting in that moment, which is pretty exciting. And again, because I tried to make that care as low barrier and as possible, we chat about if they have all of their blood work already done. A lot of the folks who get housed in those buildings are folks who are spend a lot of time in emerge or in hospital. So a lot of times they have the blood work already done. So if they have all that blood work already done, do they want me just to start prescribing right then and there, if it's appropriate, or to do the special authority, or and if that's okay with them. So I try to chat about informed consent right in that moment if they feel like they are comfortable and ready to give it in that moment. Because oftentimes I have found that Hep C is kind of this this like cloak, or this heavy cloak that folks carry around all of the time. And when you have that discussion to say like, hey, like in 8 weeks or 12 weeks, you get to take off this heavy cloak, you can really actually like see it on their face that they get to like shrug this off. And it's a really rewarding conversation to get to have. And so if they feel like they are able to give that informed consent, and they feel ready to do that, we can have that conversation right there. And then I can review the blood work or see what's outstanding separate from them. And we can get to that treatment started, sooner rather than later. And I also, even if they're not on OAT, or even if they're not on safe supply in that moment, I don't like to delay starting DAA to get them, stable on methadone, or stable on Suboxone or CATIE, or whatever it is they want to start. I think I have been able to start hepatitis C treatment DAAs, and then that other stuff can stabilize later. I think it's appropriate to wait for that to stabilize and then start other stuff, and then start DAAs later. I think that medical gatekeeping is inappropriate, because to me that sort of fits, and I think Tim was saying a bit of this, that sort of harkening back to making sure patients are like motivated enough, which we need to get away from that. And then, I chat about what blood work might be outstanding. And then I also chat about, are there any friends or family members that you think we should also get connected with, and then also get connected to treat, because, just as when you're sort of prescribing safe supply, that's in Hep C, we use the term microelimination, but also if you're prescribing safe supply, it'll be familiar with you that, if you cannot just treat like a person, you have to treat like a community, right? So it's the same sort of idea. And then separate from the person, I will sort of do a review of what labs need to be done, do any drug interaction checking. For me, with the work that I do, typically the choice between Mavorite or Epclusa usually comes down to drug interactions more than anything else. And then for follow-up, if I'm seeing them for follow-up with safe supply, most of the time the check-in around their Hep C treatment can be rolled into that quite easily. Like certainly in terms of workload, safe supply is a much bigger workload than Hep C after that initial appointment. And then for blood work, we are usually following up to do their SVR blood work, unless there's other blood work that's clinically indicated in between. I will say the folks that I see don't tend to have advanced liver disease, so it tends to be quite straightforward when it comes to the blood work. For barriers and facilitators, these are probably pretty Alberta specific, I will say. Really to be quite frank, the biggest barrier is that drugs continue to be criminalized. So as a result, people who use drugs to continue to be criminalized. And so as a result, they continue to be pushed to like the margins of society and hurt by our drug policies. So rather than get into the nitty and gritty of these barriers, I will say that is our biggest barrier that continues to happen with elimination of hepatitis C. For facilitators, it helps to treat the community. So treating not just the person, but the people that they use drugs with, that's helpful, because that treatment as prevention is very effective. Again, using that health equity approach, not waiting for someone to appear motivated enough. That's really helpful. You really just want to, as soon as they say, yep, I'm ready, then they're ready, then we're doing it. We're doing all of the things to lower as many barriers as possible and get them on treatment. Yes, I said no fiber scan, that's no longer required on our special authority forms for the medication, and we don't have to have a genotype anymore. And in Alberta, we're lucky enough, we have the reflexive testing that Rivka was talking about. So for us, we do one blood draw and it does the antibody as well as the PCR. So that's lovely. So my big takeaway points from doing Hep C treatment, as long as drugs remain criminalized, Hep C treatment will be essential for the care of people who use drugs. There are positive non-liver benefits. I know we think about liver cancer, and that's certainly important, but the benefits to clients are also, I see increased self-esteem. There's just all of these non-physical benefits as well too, that you can just really, you can just see it among folks that are just quite lovely and just quite rewarding. And you don't see that, often in this line of work. So that is worth it as well. It's just, to that second point, it's the most rewarding work I think I've done. I would just highly recommend it, and co-locating it with Safe Supply, it just decreases even more barriers, which our healthcare system is just so good at putting in place. So it makes sense to co-locate it, not only just for access to prescribers, but access for blood work and all of that follow-up care as well.
Great, thank you for that, Patty. Yeah, and I think that was a great presentation. I think one of the key points I just want to reiterate among the many really great points you made is that concept of being able to simplify treatment. For people in the audience today, obviously depending on things like your clinical judgment and as well as regional policies on these sorts of things, but there is opportunity to make hepatitis C treatment simple, and there are ways to further simplify it as well. And I think which is a key part of being able to provide a flexible, low barrier program for some of your clients. Okay, so I'll pass it over to our final panelists. So I'll invite Angie and Jessica, who are based out of the Safer Supply program at South Riverdale Community Health Center. So Angie and Jessica, over to you.
Thanks so much. Jessica, are you okay with Angie and I chatting first for a little bit?
Absolutely.
Amazing. Okay.
With Jessica.
So Jessica's over at South Riverdale.
My Jessica?
Not your Jessica, the other Jessica. Your Jessica's on vacation.
Okay.
So yeah, go ahead, Angie. You can introduce yourself. And then
I'm Angie. I'm a Safe Supply user, and I went through the Hep C program.
So we figured what we do is just a quick question and answer with Angie to talk a little bit about how she got into the Safe Supply program and then how she got connected with Hep C care, as well as what worked really well for her and anything that she wants to give as far as feedback on the programming. So Angie, how did you get involved with Safe Supply in the first place?
I heard a lot through my peers and through my workers at the injection sites that I go to. I heard it was a really good program, but I'm a very procrastinator. I'm gonna go and I'll make it there when I do, which seems to be never. But my workers really enticed it and told me what a good program it was. So I decided one day that I might as well. I'm here, so I'm going to do it. Excuse me, and I did.
Yeah, and so before you started with Safer Supply, did you know you had hepatitis C?
Yes, I did.
So tell me a little bit about access to treatment. So were you able to get Hep C treatment before Safer Supply? Was Safer Supply the only place it was offered? How did that work?
No, I was able to get treatment before I was into the Safe Supply, but it just made it easier because my Safe Supply and my hepatitis C program are both in the same building. And the staff made it a lot more easier to want to come back. Like, they just make everything good. I don't know, it's hard to explain. They make you feel comfortable. They let you know everything that's gonna happen every step of the way. Like, you don't get some surprise, like something that's gonna happen to you around the corner. That's gonna be some big surprise of that you have to take 10 more weeks of medication, or like or some crock of shit like that. Like, they let you know everything that's gonna happen every step of the way. That helps a lot.
So I think one of the things we talked about is that there's a lot of money in education right now, and talking about like telling people about Hep C, about the medication, about that kind of stuff. Do you find that to be helpful, or are there other things that we need to be doing to help people connect to Hep C care?
See, I don't really know. Like, it took me forever to get on this program. And people aren't going to want to come unless they want to. It doesn't matter how much money, or it all has to do with you. It was you guys that made me come here. Like, I found out I got $10 for coming here after I started coming, like, which was a surprise to me. All I think is you guys need to talk to a few people. Like, that's what made me come.
So was there anything that you see that could have been done better, or any barriers in getting into these programs that you see right now?
No. Like, what more can you guys do? You guys stretch your necks out, like, as far as they can go. Like, the only thing you do next is stand there and offer people $100 bills, and that's impossible. I wouldn't do that.
Perfect. And anything else about like how functionally being on Safer Supply and Hep C, like doing the two together, was there any big difference for you adding Hep C program to your Safer Supply program?
No. It was no like, there were no withdrawals or nothing like that. It was just a normal procedure. I miss coming to my Hep C program now. Like, now that it's over, it's like it ended so quickly, but it ended with a big bang. Like, I don't have Hep C anymore, which is really good. I'm really happy.
So maybe we should end it on that high note there, and we'll throw it over to you, Jess. Thanks so much.
Thanks, Bernadette and Angie. I'm just going to share my screen. My name is Jessica. I'm a nurse practitioner at South Riverdale in the Safe Supply program. Sorry, 1 second here. And I've had a lot of technical difficulties today. So I'm just gonna, go through these slides as they are. I'm not going to really talk too much. I feel like what the other presenters have said have really, I echo their sentiments for sure. So at South Riverdale Community Health Center, we're very lucky in that we also share space with the Toronto Community Hep C program, which Bernadette and Angie were both part of. And really, the Hep C program and Safe Supply are really organic and naturally aligned. So we service the same providers, the same populations. So, folks that have barriers to accessing healthcare may not have had great experiences accessing healthcare in the past. Folks that are underhoused, people who use drugs, and we really also operate from the same philosophy of care. So harm reduction, being client-centered, so meeting clients where they are at, holistic and interdisciplinary. And I really think that, as we've heard in this talk, that Hep C care and Safe Supply are sort of naturally they're adjunctive to each other, right? So the harm reduction aspect is really important to ongoing Hep C care, treatment, and prevention, and we can offer that within a safe supply program. And interestingly, the safe supply program at South Riverdale, when it started, the intention was for it to kind of mirror the Toronto Community Hep C program. So having peers being very heavily involved, group setting, social support for clients within the program, but COVID sort of threw a wrench into all of that. And we are now starting to look at potentials for groups. So in terms of our programs, so referrals to our programs kind of go both ways. So there are RNs within both programs that consult with each other. If we have a safe supply client that needs referral to Hep C or vice versa. When we see our safe supply clients initially, we offer screening for Hep C at program intake, and we refer to the Hep C team based on the results of that screening. We do also look at blood work, before we do intakes for our clients. If they're historically antibody positive, we will offer HCV RNA testing to confirm infection. And then, if there is need for treatment, this can be carried out either by the Hep C team provider or a safe supply provider. Because we are able to sort of co-locate our services, the actual treatment and care is very seamless. The other thing that we've done is, for our clients that receive care from both the Hep C team and from the safe supply team, is that we've created a sort of a drop-in clinic on Wednesdays from 1 to 3 that runs at the same time as the Hep C group and drop-in, so that clients can come and they can see Hep C, they can meet with Bernadette or their prescribers, and they can also come to a safe supply. So it makes it really easy for folks to access care. And then we work collaboratively for monitoring, medication course, and follow-up. And also, clients can be referred or re-referred at any time. So let's say we have a client in the safe supply program who, for whatever reason, kind of falls off of the program, but is still connected to Hep C. We're, open to having them come back to see us. And the same thing, if a client has a reinfection of their Hep C, we can re-refer back to the program. So some benefits for the clients. So like I said, clients can access both teams using the same drop-in model on the same day of the week. So folks can really get care that they need when and how they need it. And we try to, really focus on what the client's goals for care are. Some people that come to see us for safe supply don't initially want Hep C testing. And so, we offer it and we say, when you're ready, we can do it. And then folks are able to kind of feel comfortable reapproaching that when they're actually ready to receive care. Again, like other presenters have mentioned, Hep C medications can be daily dispensed with safe supply medications, which makes it really easy for clients. And I also think that by sort of co-locating our services, clients have access to sort of multiple supports when they come in. So medical care, be it other testing for bloodborne infections, social supports, tokens, honorarium, and treatment for, they can get their safe supply treatment, Hep C treatment, etc. And then the other thing that I think is really important is that as safe supply prescribers, we are really in long-term relationships with our clients. So we can help support ongoing follow-up. So rescreening people every 6 to 12 months, again, re-referring them to programs, helping to support harm reduction to reduce their risk of reinfection. So that's really why I think we're very well situated to support people in their treatment. So I think some benefits for the care team that comes from having these two programs that work so well together. One is we have a wider net to support our clients. So if we haven't seen someone in a while, we can ask the Hep C team, have you seen Bob? And if they have, they can support Bob coming to see us for safe supply. I also think the integrated model builds provider and worker knowledge, which in the end is going to create better care for the client. And as has been said multiple times during this presentation, that Hep C treatment is simple for most safe supply clients. And the Hep C team is really there to support us when we run into more complex cases and can help facilitate connection to, let's say, the liver clinic specialists, or really just to review how to support clients that are just have a little bit more of a complex presentation. So some of the lessons that we've learned is really that if you're looking to kind of start doing this work as a safe supply prescriber and you want to partner with other programs, so look for programs that have successfully served your population. How are they structured? Can you offer a similar model? And when you're collaborating with other programs, create some flexible clinic structures to improve access for clients. So drop in looking at time of day, when are folks accessing your programs. And then collaborate with programs that operate from the same care philosophy. So this is going to benefit the client. We talk a lot at South Riverdale about integrated drug user health and sort of how can we create an environment where people can come and they can get care that is non-judgmental and supportive and meets them where they're at, and sort of reduces the stigma that they've faced within the healthcare system. I think groups and social connection are really important, and that can actually be a draw for folks to come into Hep C care and also for safe supply. And really, we are, as safe supply prescribers, very ideally situated to provide care to folks that need Hep C care. So thank you very much, and I'll hand it back to Chris.
Great, thank you, Angie, Jessica, and Bernadette for that section. Yeah, certainly some great messages there. I just want to reiterate like the last piece about, hepatitis C care can be delivered through that harm reduction lens using the philosophy and values of the way care is delivered, including that like sort of grassroots community-led aspects of it. So I really just want to focus on that. Okay, so I think I'm gonna hand it back to Rebecca because I believe there's a few polls that are
just thanks, Chris, and sorry to interrupt. Just very quickly, we're going to ask, we're going to put up a poll and ask that you just fill it. It's a very, very quick poll. And also you might want to add some more questions. If you have questions, Chris will open up the Q&A after. So there's a Q&A text box. You can put your questions in there so that Chris can take those up with the panel. Thanks so much, everyone. Just give it another minute. Chris, I think you can have a look at those questions and carry on while people do the poll. Just thinking of time.
Sure, as long as we can do it with the polls in the background. Okay, so I'll invite all of our speakers to come back on camera. We don't have a ton of time, but I hope we can answer a few quick questions as folks complete the polls. So the first one we got was more of a kind of, I guess, biomedical content question. So someone is asking, so if someone gets hepatitis C more than once and receives treatment more than once, they're asking, is treatment equally effective each time? Or is there the potential to build up some sort of immunity or tolerance to treatment? So Rivka, maybe I'll direct that over to you first, and then Tim or Patty, feel free to add in, or Bernadette as well, feel free to add in any content afterwards. But Rivka, do you want to start us off?
Sure. So I don't know of any evidence that indicates that hepatitis C is less effective with multiple reinfections. The direct-acting antivirals are highly effective treatments, and the evidence that I've seen points to them being equally highly effective for reinfections.
All right, thanks, Rivka. Anyone else have anything they want to add about their experiences about doing retreatment or treating reinfections?
Sure. So I definitely agree that the medications are effective. The interesting thing about hepatitis C, because it's a virus that ends up being cured, you're looking at the virus, not the person, when you're talking about treatment naive or treatment experienced. So if somebody's had a course of treatment and cleared their virus, then a new infection is a treatment naive infection because we're talking about the virus, not the person. Okay. So that's a lovely way to kind of remember. If we're talking about somebody who was treated with a course of medication, the medication didn't work, and then we're looking at treating another course with the same virus, a different medication, and it didn't work, then there's potential to build up resistance. But if the medication is given, they clear the infection, then the new infection is a treatment naive infection. So that's the comfort that you can take with somebody who's being reinfected with new infections multiple times. The only thing that I would say is that there's most likely some work to be done to figure out like what's happening in this person's environment as to why they're continually at exposure. Is this somebody who has difficulty negotiating consent? Is this somebody who would benefit from having a group of individuals around them also offer testing and treatment? So looking at, I don't think that you should do the exact same thing every time, is what I'm saying. I think that the medication piece is not what we need to work on. The piece that we need to work on is making sure that that person is supported in their community and other people in that community are supported around Hep C treatment as well.
Great, thank you, Bernadette. Anyone else, anything to add on that issue around retreatment? Okay, so we'll move on, just super a lot of time left. So another person asked, so saying some prescribers had the preference to treat with Mavorite rather than Epclusa. So I guess keeping in mind that without endorsing a drug from one company over the other, from either the provider perspective or from the patient perspective, is there a reason why folks might choose to choose Mavorite over Epclusa, given maybe some of the differences around the treatment courses or any other reasons? So maybe I'll start with either Patty or Tim, if you had anything from your perspective.
Yeah, I mean, for me, I don't necessarily have a preference, I would say. I think just as Rivka outlined in her talk, the kind of the things that are weighed against each other are the 8 weeks, which a lot of people are very enthusiastic about, versus the need for the multiple pills, although still once a day, and the food requirements. And so that's the discussion that I would have with patients in terms of kind of the ups and downs of both courses, and then people tend to choose one or the other.
Yeah, for me, it often comes down to like a drug interaction choice.
Okay, great, thanks both. Okay, anything else around choosing one treatment type over another from anyone else? Okay, maybe we'll move on. There's a few more questions to cover. So someone asked if there's any contraindications to treatment. So Rivka already talked about in her presentation about pregnancy, but they're asking, is there any reason that they would not prescribe to their SOS clients? So I wonder if anyone had maybe specific examples or kind of like common things that maybe people want to watch out for related to contraindications for starting hepatitis C treatment.
Like, I do know I don't treat co-infections. Like, it's like those really like HIV Hep C infections. Like, that's something I wouldn't do independently. But those are like, if you do the in-shoe course, it goes through those type of contraindications. But that's something that would probably, that's one obvious thing I can think of with an SOS client that might come up.
And I can say that, like, with experience with Hep C treatment, there's not really any contraindications that we've had with individuals who are interested in getting Hep C treatment. So, and that includes hepatitis B co-infection, which is something that has to be managed carefully for sure, but can still be treated in a community context. HIV co-infection as well. Sometimes people end up saying, well, if there's a terminal diagnosis and somebody has a palliative course where they may not survive the next 3 to 6 months, that might be a reason to not offer treatment. But in all honesty, the majority of conditions can be managed with hepatitis C treatment in the way that it is right now.
Great, thank you. Anything else to add from anyone else? Okay. So there's also a few questions around coverage for treatment. So just a reminder, in all regions in Canada, there's slightly different rules around it, but the cost of treatment can be covered for most people. So we just want to ask what are common challenges that you faced in terms of either getting people covered for treatment? Specifically, someone asked around reinfection as well. And so I just want to ask if, are there common challenges around being able to access treatment coverage for any folks that you work with?
I'm conscious of the fact that I can talk a lot. So if anybody else wants to respond, please do. ODB coverage is quite easy. It's a limited use code that's used for that. There is criteria specifically with it that you can look on the ODB formulary for it. So when that criteria is met, it's hepatitis C viral load within the last 6 months and some evidence of chronicity, whether or not it's somebody having been exposed through injection drug use for the last year, or if they have elevated ALT, AST, something like that. The considerations that we had to go through before no longer exist. So fibrosis level in Ontario is not a consideration. With reinfection and retreatment, technically it is not covered through limited use at this point in time. What is required is an EAP application, so an exceptional access application for that. But like these are kind of like, this is why you end up having a practice group like say ECHO Hep C or other individuals that can end up helping with cases of like reinfection or more complicated cases. So there's like a very large support network for providers who don't have experience in treating Hep C and are interested in it. Technically, you're supposed to be somebody with experience treating hepatitis C. So oftentimes what we do is co-manage a case together between the SOS program and the Hep C program. And that allows the provider to have experience treating hepatitis C. And so if they want to continue with treating uncomplicated cases after that, that's absolutely a way to go. If those are the concerns, the ODB concerns.
There's also a program through like the drug companies for compassionate coverage with lost pills as well. So if someone has lost like a significant, like not one or two, but a significant number of pills, there's a way to recoup that through the drug companies. You just have to register through, I believe it's called compassionate coverage, but correct me, panelists, if I'm wrong, so that folks can complete the full course of treatment as well.
Okay, great, thanks for that. And of course, we'd ask, like, obviously every region will differ slightly. So just double check with your, provincial drug formulary or health authority on what the specific sort of rules are in your region. Okay, we only have a couple minutes left. So just conscious of that. So maybe I'll just ask our panelists, are there any final parting words or sort of words of wisdom that you want to share with our audience for folks who are kind of maybe on the fence or are planning to start providing hepatitis C treatment?
I just said, okay, go ahead.
I'd advise you, if you haven't done it, do it. It's a great program.
I don't think I can say it any better than that, so I'll just echo that.
Okay, maybe we'll leave it there then, just for time. So big thank you to all of our speakers today, to Tim, Patty, Angie, Jessica, and Rivka. Thank you also to the National Safer Supply Community of Practice for having us today. As a reminder, we'll follow up shortly with some information around how you can register for those follow-up hepatitis C trainings. Big thanks for having us and for attending today. So with that, I'll pass it back to Rebecca to close up the session.
Thank you, Chris. Thank you, Katie, and thank you to all the panelists. It was a great conversation and perfect for us to have today on International Hepatitis Day. Thank you all for joining us today. And we will be sharing all of the resources that people talked about today. You can find them at the CATIE website, but we'll also post them on our website along with the video. We'll probably have that all up by tomorrow. And you're able to watch that at a later date and time and share that around with your colleagues as well. And we hope that you'll join us at the National Safer Supply Community Practice with our other events. We have our next webinar. Our hot topic webinars are the last Thursday of every month. And next month we're having harm reduction, safer supply, and pre and perinatal care panel discussing those issues. So, and some really great stories of what's happening out there, the amazing work that's happening. So thank you all again. And thanks to CATIE for doing this with us. It was wonderful to have you. Look forward to more.